on non-communicable diseases, which are, as we have learned from previous presentations, are still the major killer across the globe, but have been eclipsed a bit by the last 2 years with COVID. So we're glad to get back in touch with colleagues doing work on the ground on these issues. The way we'll run this session is that our first presenter is going to be presenting by video. He presumably has about 10 minutes. I hope not much more than that. And Dr. Helen Elsey is here, who is a collaborator on his project to be involved in the discussion. And then each presenter will get about 10 minutes. We'll do 1 or 2 questions and answers after each presentation to maintain time, to make sure everybody gets to present. And then if we have any time at the end, we'll open it up for broader questions. So active listening for each presentation, get your questions ready because you'll have some time to do that. So I'm going to ask each speaker to speak from the podium and to introduce themselves as they come up. So I think we'll start. Deepak Joshi is the first presenter from Nepal, and he's going to be discussing participatory methods to identify the urban poor and NCD care-seeking place in Pokhara, Nepal. And so we can run his video.
Good morning, everyone. I'm Deepak Joshi. Today I'm going to share our work in implementing the participatory methods to identify the urban poor and NCD care-seeking place in Pokhara. So this activity is under the project called Community-Led Effective and Responsive Urban Health System, also known as the CORES project. Before going into the methods in detail, I would like to briefly mention you about the study context in Nepal. So in Nepal, there is 3 tiers of government, one at the federal level, one at the provincial level, and one at the local level. So Pokhara Metropolitan City is one of the local bodies. Talking about the urban health, so in the last 10 years, there is more than 3-folds of increment in the urban population. Evidence is suggesting that there is increasing poverty and inequity in healthcare service relation in urban areas. And also studies suggest that there is high out-of-pocket expenditure to access the basic health services like NCD care services by the urban poor community. So in this project, CORES, we are mainly focusing on 3 important aspects. One is the basic health services, under which we will be focusing more on to the NCD care services. Then we will be focusing in the urban poor community and the linkage with the private healthcare providers. So currently there's very limited service and data linkage with the private sectors, and there is a very weak regulations in the existing government system. And the overall objective of this project is to understand what are the possible approaches that we can adapt at the local level to engage with the private healthcare providers in delivering the quality services, so that leaving no one behind, including the urban poor community. So these are the specific objectives under our project, but however I will be mainly talking about our activities, our experience related to mapping the urban poor community and the service providers in Pokhara Metropolitan City. So in terms of identifying the urban poor, so we use this funnel approach to identify the urban poor. So we started with the stakeholder mapping at the local level at the Pokhara, where we identified the key stakeholders in terms of the individual or institution. We had a consultative meeting with them, we did a workshop, and the main purpose was to understand their perception of the urban poverty and the understanding the prevalence of NCD disease and its distribution in 33 wards. And based on those discussions, we prioritized 2 major wards on the basis of the prevalence of the urban poor people and the NCD healthcare service utilization. Of those identified wards, we again approached the stakeholders of those wards, that included the locally elected representatives, the health facility in charges, the female community health volunteers, the social workers who have been working there, uh, and we did a social mapping exercise with them with the help of this OpenStreetMap. And before entering into the social mapping exercise, we firstly discussed with the participants on their understanding, their perception towards the urban poor or the poverty. And then based on that understanding, we marked the settlement in the map. So how we define the urban poor? So there were different areas that were discussed under the urban poor. So one was like the household position of the household assets, like the TV, fridge, or there's vehicles, motorbikes, the land ownership, the income source, the household infrastructures, access to healthcare services, the schools, uh, and of those different areas, we came up with an understanding that at least two important areas, that is the main source of income, if it is daily wage labor or a low paid salary job or a government allowance, like the allowance given to the elderly people or the differently able people by the government, and they have the difficulty to access the healthcare service during the illness. So these were the major two criteria that has to be fulfilled in order to define the urban poor. And after coming up with this agreement, so we mapped the households in the house settlements in the wards in the selected clusters, and in the third phase we approached one cluster in each ward, where we again identify the key stakeholder in that cluster, that is like the female community health volunteer, again the health facility in charge, and the local cluster leader, that is called the toll leader. So we identified, held a discussion with them, again the consultative meeting, and also did a transit walk with them in the selected cluster. And after completion of the transit walk, and then we again sit with the stakeholders and identify the households based on the disaggregation of the age, gender, and their health condition. And then we recruited those participants in the focus group discussion and the in-depth interviews. So these are some of the key findings from our focus group discussion and the in-depth interviews. The risk perception towards the hypertension and diabetes is very low, as people perceive it's very common, and their exposure to the risk factors like the alcohol, the unhealthy food, the stressed working environment is comparatively higher. And also they have low utilization of the social health insurance that is provided by the government at a very low cost, and especially to urban poor it's provided free of cost. However, its utilization is very low. And also we found that their proximity to the pharmacies is comparatively better, and that's why they tend to utilize the service from these outlets. And there is also difference according to the age and gender in seeking the care, and there is a kind of high dissatisfaction towards the public health providers. So these are the major findings. And during this participatory methods like social mapping, the transit work, and focus group discussions, we also discussed with the participants and did this rating exercise, where we discussed on the distance, the affordability, their personal comfort, and information, based on which we asked them to rate which of the health facilities is more accessible to them. And it was found that the private sector, particularly the pharmacies, were the more accessible. It is mainly due to their proximity, the community linkage, as the shopkeepers, they mostly belong to the local neighborhood, and also the responsiveness. As I remember one of the participants mentioning that it was already like in the evening 8 or 9 p.m. she had a severe headache, and by that time the public facility was already closed, and she made a call to nearest pharmacy shopkeeper, and he responded quickly. He come up with the medicine as he was living nearby. And in most of the instances, like even when they don't have money, they offer them medicine on a credit basis. So in this way they have a more trust and access to the pharmacies. Whereas in the public health facilities, like which are opened from 10 a.m. to 5 p.m. So these service hour also coincides with their working hour, particularly like the daily wage labor or the person who goes for the job. So they don't want to lose their job work just because they have to seek the care service. So they tend to go in the early morning or the late evening hours, and on that regard also they find pharmacies more accessible. And also we did GIS mapping of the service outlets and the slum settlements, where we coordinate with the city level stakeholders, the municipality officials, and also at the ward levels officials, so that we don't miss any. This is the heat map that shows the distribution of the slum settlement in Pokhara city. This is the distribution of the public health facilities according to the slum settlements. As we see that urban health clinics are more in numbers in these slum settlements. And this is the distribution of the private health facilities, particularly the polyclinics and the clinics are in the nearest distance to the slum settlements. And this is the distribution of the pharmacies. There are altogether 660 health facilities in the Pokhara city, of which 353 were the pharmacies. And besides the GIS mapping, we also did the health facility assessment, including the pharmacies. And of the total pharmacies, nearly 80% of them were delivering either diabetes or CVTs or both related care services, besides the dispensing of drugs. And of those pharmacies providing the services, 42% of the healthcare providers had the paramedics background. The same background of cadres are delivering the pain package from the public health facilities. The pain package is the package of essential NCD care services that was developed by WHO and has also been adopted by Government of Nepal. Now coming to the concluding remarks, so we found this social mapping exercise as an effective tool to identify the urban poor households using this funnel approach. As urban poor mostly rely on pharmacies to seek the service so it becomes important for the local government to engage with them. And there is this social health insurance which is provided free of cost to the urban poor people, but still it's not in reach of them. And there is a weak coordination among the different tiers of government and within the municipal stakeholders, and there is a weak formal mechanism to identify the urban poor people in the community. So this kind of method could be a useful tool for the local government and the other organization working in the sector. Thank you all. Any questions and queries are welcome. Thank you.
Okay, thanks. We're back. Very good, because the other speakers are coming up. All right. Anyway, well, thank you, Helen. And I think this issue of pharmacy, since we have a number of presenters from this region, is going to come up again. We probably want to spend a little bit more time on it. So let me invite Santhushya Fernando from Sri Lanka to come up and be our next presenter. Thank you.
Hi, everyone. I'm Santhushya Fernando from Sri Lanka. Okay, so the research findings that I am presenting today is on the prevalence and clustering of cardiometabolic risk indicators in the city of Colombo in Sri Lanka. As you know, the cardiometabolic risk is a cluster of risk factors involving a lifestyle, physical activity, diet, alcohol consumption, the way they live, their demographic features such as age, race, where they live, their domestic wealth, and so on. And these cluster of cardiometabolic risk factors give rise to cardiometabolic diseases like hypertension, diabetes, dyslipidemia, and obesity. But the cardiometabolic risk is a complicated thing because some of the cardiometabolic diseases are in turn risk factors for some other diseases themselves. For example, obesity is a disorder in itself, but also a risk factor for myocardial infarction or hypertension. So they exist in a complex system. So the objective of my study, our study, was to estimate the prevalence and clustering of four disorders: hypertension, diabetes, dyslipidemia, and obesity, and the factors associated in the Colombo Municipal Council area. The Colombo Municipal Council area is the most cosmopolitan and the urban and the industrialized part of Sri Lanka, with a population of 626,000 people compacted in a small geographic area. It has a lot of affluence and a lot of poverty. On a good day, on a good night, Colombo Municipal Council looks like this glittering image by night. Where there's a lot of nightlife, a lot of affluence, a lot of fun happening. But if you see the other pictures at the other side of this slide, by day, it can look like that too. So a lot of inequality, poverty, crowding, and underserved living conditions are found in the Colombo Municipal Council area. So the methodology of my study was a cross-sectional analytical study, and the participants were recruited to the study by a multi-stage clustering sample from the Colombo Municipal Council area. A calculated sample of 1,350 participants were selected between the ages of 35 to 64-year adults. A validated questionnaire, initially developed in India to capture the cardiometabolic risk-related lifestyle called the CARS, was validated to Sri Lanka before using it on the Sri Lankan study sample. And as a part of this study, GIS location and clustering of the risk lifestyle factors and factors associated and the cardiometabolic risk outcomes were also plotted as a part of this study. So the data generated were on the prevalence of hypertension, diabetes, dyslipidemia, and obesity, and also the factors associated were also collected and mapped, which were the socio-demographic features, the physical environment, lifestyle, such as smoking, physical activity, diet, and alcohol. The serum tests were done to measure the fasting blood sugar for diabetes and the fasting lipid profile for dyslipidemia. So the prevalences were calculated and the significant risks were calculated by bivariate and multivariate analysis. And the GIS mapping was done by using a software called the ArcGIS software. And the outcomes such as hypertension, diabetes, dyslipidemia, and obesity were mapped. So these data were layered on the GIS mapping system, where they were layered on top of each other to find the collated risk in these administrative areas within the Colombo Municipal Council area. So the area level distribution, therefore, were depicted through GIS as well. So the prevalence results were hypertension 42.3%, diabetes mellitus 28.1%, dyslipidemia 63%, obesity 58.9%, very high rates compared to the national averages. So the factors that were statistically significant for hypertension, diabetes, dyslipidemia, and obesity were for hypertension, male sex, older age group of 55 to 64 years, and inadequate physical activity. For diabetes, it was the age category of 45 to 54 and the more ethnicity. For dyslipidemia, it was male sex and unsatisfactory domestic wealth. For obesity, once again, the more ethnicity and inadequate physical activity were found to be statistically significant. When we come to the GIS data, there were many maps that were created through data analysis. I will not present all of them here, but we generated risk clustering for each factor and each outcome that we measured in this study. So 4 clusters, risk clusters, consistently emerged as a risk area for all the 4 disorders and all the factors associated, namely Modara, Matakulia, Madampitia, and Lunupokuna. Within these municipal council, the Gram Niladari divisions or the administrative areas, there was yet more clustering within that administrative division as well. So we could kind of pinpoint where within an administrative area within the Colombo Municipal Council, where it was actually in real time clustering. So coming to discussion, there's a high prevalence of hypertension, diabetes, dyslipidemia, and obesity. And I must also mention here, the response rate for this study was 94%. And out of that, over 70% people who consented to taking part in this study were belong to the poorer groups of society. So we can actually infer that in this study that these very high prevalences we saw probably originated from the poor and the underserved. And the risk in lifestyle disorders were depicted in clusters. We could identify the clusters, and the preventive action can target the geographical risk pockets in the Colombo Municipal Council area. That's all from me.
Why don't you stay here, Cereijo, in case there are any questions? You want to come back? This is the only microphone, so are there questions for the presenter? I'm gonna ask a question while everybody's thinking up their question. You mentioned the geographic clustering and obviously obesity being a big issue, et cetera. Could you comment a little bit about whether Colombo has gotten involved in any changes in the physical environment, the built environment, to try to address these issues, or is that the kind of evidence you want to bring to the attention of officials to get them to do something? You want to comment on that, please?
Actually, the city of Colombo has undergone some transformation maybe in the last 5 years, where the physical environment, walking paths, walking tracks, green areas were actually upgraded in the city of Colombo. Probably we have to do some follow-up data collection to compare them, because they have only consolidated around now. So I think maybe this is an opportunity for further data to collection of further data to understand how with the improvements made in the physical environments have actually impacted the NCDs.
Great, thank you very much. Any other questions? Okay, we'll move on. Thank you. Maybe at the end. Thanks very much. Our next presenter is, oh, I don't have to do that anymore. Our next presenter is Luis Tejedor, and he will be talking to us, shifting over to Madrid. So if you'll introduce yourself and your traffic, thank you.
Well, good morning, everyone. Thank you for being here and for sharing your time attending our communications. My name is Luis Cereijo. I'm working Universidad Alcalá here in Spain and in the RMIT University in Melbourne, Australia. And well, let's go with the presentation. Firstly, as all of us know, built environment exerts a great influence on population health, and especially the field that we study about physical activity environment. However, we should considering that there is a lot of difference between the different physical activity features in the urban settings, and especially between the physical activity or the type of physical activity that these destinations provide to the population. For instance, streets provide a physical activity related with active transport. It's not a leisure time physical activity, and it's a light physical activity. Parks, green spaces, open spaces, etc., is a very common destination for leisure time physical activity, including a moderate physical activity, but is a physical activity without supervision. And this issue is very important when we talk about changing behaviors and lifestyles. And finally, we have our favorite, exercise facilities, that we think is very, very important for several reasons. First, exercise facilities provide exercise. That is physical activity, planned, structured, and purposive. And the activities that the exercise facilities provide are very linked with moderate to vigorous physical activity and supervised physical activity. So all of that, therefore, exercise facilities are very, very important destinations in population health research when we talk about health benefits on populations. So the objective of our study was to analyze the associations between availability of this type of destinations, exercise facilities, and incidence of type 2 diabetes and microvascular, macrovascular complications, what are disease very, very important linked with physical activity as a risk factor, and to explore the effect of area level socioeconomic status and sex on these associations. For that, we count on a sample size of 1.2 million people from Madrid, from 40 to 75 years, which represent more or less the 95% of the total population of this age group. We divided the entire sample size into two subcohorts. One, with only the people without type 2 diabetes diagnosis at baseline to assess the analysis for incidence of type 2 diabetes. And another one, the cohort B, with people with diabetes at baseline, but without any microvascular, macrovascular complications diagnosis. We used electronic medical records on a population-based retrospective cohort. As we said, the first outcome was type 2 diabetes. When we talk about macrovascular complication, we're talking about ischemia, cardiac ischemia and stroke, and microvascular complication are retinopathy, nephropathy, and vascular peripheral disease. To assess exercise facilities availability, we use geographic information systems, and we carry out a 1,000-meter street network buffer around each dwelling, more or less 200,000 dwellings in the entire city of Madrid, and count every exercise facilities within each buffer. Finally, statistical analysis was a Poisson regression models with robust standard errors to assess relative risk of each outcome. And then we carry out the same analysis with interaction term, with tercets of area level SES and sex, and all the analyses were adjusted by population density and age. Firstly, we found in the first analysis that there is an association between exercise facilities availability and incidence of type 2 diabetes, microvascular complication, and macrovascular complications. However, when we introduced area level SES in the model, we found a significantly reduced of the association. Therefore, we decided to explore if could be an effect modification by area level socioeconomic status. And in the stratified analysis, we found this. Those people, the red point, the highest red point, those people with living in areas with the lower level of exercise facilities availability and lower SES have the stronger association between exercise facilities availability and incidence of type 2 diabetes. And we can see how the association decrease as the area level SES increase. So we can see a clear effect modification by area level SES in overall people and stratified separately men and women. On microvascular and macrovascular complication, we also can see that people with lower availability of exercise facilities have a stronger association between exercise facility availability and incidence of microvascular and macrovascular complication in low CS areas. However, the results in gender and medium and higher CS are not so clear as in type 2 diabetes results. Finally, as conclusions, areas with low availability of exercise facilities show higher incidence of diabetes and its complications. This association is even stronger for neighborhoods or areas with a lower socioeconomic status and for men. Our findings support the contribution of exercise opportunities in the social gradient of diabetes, and as a policy recommendation to take away to home, we want to share that to increase exercise opportunities could help to reduce health inequities and flatten the social gradient of diabetes burden, especially in those areas with the lower exercise socioeconomic status and a worse quality of public policies to reduce health inequities.
Thank you very much. Very well done. Right on time. Do we have questions for Luis? Yes. Please just identify yourself and Mike is coming and ask your question.
Letícia Cardoso from Oswaldo Cruz Foundation in Brazil. Congratulations for your presentation. And I would like to know if these physical activity facilities are public or paid ones, because for me, it's, I don't know if there is some public ones in Madrid. And another thing that I thought, did you adjust for green areas in the buffer or parks or something else? Okay, thank you.
Okay, thank you for your question. Yeah, we analyze all the exercise facilities. Our definition to understand a lot is more or less fitness centers, gyms, etc., and are public, private, low-cost facilities. And one term that we create is sessional facilities, that are those facilities where when you pay per session, like Pilates, etc. So all the exercise facilities in the city. And the second question, yes, is our next step, is to try to understand how interact exercise facilities, public open green spaces, and walkability together in health inequities through physical activity and exercise specifically. Thank you.
I'm going to take one other question.
Thank you very much. Manuel Franco, also from Madrid. Thank you, Luis, for your presentation. After seeing the presentations from before, dealing with chronic diseases, diabetes from very large places far away in the world for large cities, and then coming back to you in Madrid, what you were able to show, it's a very interesting example of this, what we call equigenic effect. So the fact that these contextual characteristics of our cities may help reducing health disparities, which is something that is a big goal of what we do. Why do you think exactly in Madrid that happens, or how could that have happened, and what can you tell us in this conference?
Yeah. Well, exercise facilities interact from a very strong way with individual socioeconomic status. Those people from low SCS areas, we can expect that they have a worse state of health. So the start point is worse than the rest of the people in the city. We should clarify that our results talk about the association between exercise facilities and incidence of type 2 diabetes. So I think that our results express that those people with a worse state of health, and talking about health, talking about a lot of things, need the most exercise providers, they are the people where we have to put the focus of public policies, especially sport policies, and provide them the most capacity to provide exercise from the public institutions. They need more exercise opportunities than the people from high SES areas.
Okay, great. Thank you very much.
Okay, thank you.
Come back at the end. All right, and now we're going to move to Latin America. This is certainly a global panel, which is great. And I'm going to invite Diane de Oliveira to present.
Hello, everyone. Good morning. My name is Diane Oliveira. I'm going to present today the effects of social and beauty environments on cardiovascular disease mortality for Latin American municipalities. This is a celebrated study, which I'm a member of, and we mainly study health inequalities in Latin America. We are granted by the Wellcome Trust, and our working group is like urban health. Let's get started. So, as we all know, non-communicable diseases has been the major cause of death worldwide, with approximately 70% of all deaths due to non-communicable diseases. And we have a very similar picture in Latin America. About all deaths in Latin America is 75% of them are non-communicable diseases. And among those, we have 27% being from cardiovascular diseases. What is unequal in Latin America is how those deaths are distributed between and within countries. And also Latin American countries are in different stages of the epidemiological transition. Also, in Latin America, we have 80% of our population living in urban areas. Also, in these urban areas, we have large social and cultural features inequalities between and within countries. Maybe it's kind of easy to picture a country is unequal than the other, but in Latin America, very common to see this picture on our slide. You can see a very wealthy neighborhood on the background with more advanced urban features. And here in the foreground, very near to this wealthy neighborhood, we have a very poor neighborhood with very low urban infrastructure. So we believe that this urban and social inequalities between and within cities may help us understand the distribution of cardiovascular disease death in Latin America. So our main research aim is to explore the associations of social and good environment features and cardiovascular disease mortality in Latin American municipalities. To do so, we are counting with a sample of 1,254 municipalities distributed in 343 cities for 9 Latin American countries. Our unit of analysis is the administrative unit, and we designated this in Latin America as comunas or municipalities. And this is geographical boundaries nested within the city level. We're using data at the municipal level for mortality of cardiovascular disease divided by age and sex, and we redistributed the ill-defined causes. And we are using social and environment features. We are exploring this analysis for Argentina, Brazil, Chile, Colombia, Costa Rica, Guatemala, Mexico, Panama, and El Salvador. We are trying to use the most updated data we are available with. So mainly we are using data on 2016, except for El Salvador, we have information on 2014. And the census data is for our social environment features, and beauty environment data is as close as possible to the mortality data. So our social environment indicator, we are using the census-based index of population education attainment, where we combine information of the proportion of population aged 25 years or older who completed secondary and university education level or above. Our beauty environment indicators, we are using the adjusted total population for an accounting of each municipality by age and sex. We are using street intersection densities to measure urban connectivity of these municipalities. Mean patch size to measure landscape fragmentation of the urban expansion, and natural environment metrics of NDVI to measure greenness. And this is our model. We are trying to combine this association with Poisson multi-level models of our municipality units nested within the cities and the country level. We have run the intercept between them. And this would quantify the relationship between the social and beauty environments and the increase of death counts for cardiovascular disease. And we are correcting the model using the adjusted population by age and sex as an offset term. I'm not gonna get into statistics a lot here, but here's our beta zero, and we have the coefficients for social adjusted by urban, age, sex, and the last one is the offset term as our adjusted population. I hope you can see it clearly. So to facilitate our understanding of this graph, I ordered these countries by GDP per capita. So we have the wealthiest countries in Latin America in the top and the worst one in the bottom. And the first dot is the overall analysis between all of them. As we can see, generally, we can say the higher social environment of education attainment is related to a protective effect or cardiovascular disease mortality. And it's also maintained for Panama, Chile, Argentina, and Brazil. And however, for Mexico and Guatemala, we see a risk association. For Guatemala, which is in the bottom, it's kind of expected. It's one of the poorest countries we are evaluating. So it's also on later transitions of the epidemiological transition, later stage of the epidemiological transition, but it's not as so expected for Mexico. It's kind of in the middle of all these countries. However, since we are analyzing this at the municipality level, Mexico is a high unequal country. So when you put this on a lower level, this may help understand this information. Here's the information for NDVI. I find it interesting because we have two polarizations here. We have one important results for Panama of a protective association of greenness. So higher greenness is a protective association for cardiovascular disease in Panama, but in Colombia, it's a very important risk association. And when you research for greenness and non-communicable diseases in general, you normally see more advanced countries, the wealthiest countries, reporting as a protective association. And here in Latin America, we have a polarization very important. So it's very nice to see this kind of research. And Colombia is very near to Mata Atlantica and Latin America. So it's quite important. Our built environment results for street intersection. At the municipality level, you don't see a very clear position here. You do see that, for example, Costa Rica has a risk association, but I'm not sure if you can look at this log there, but there's a very low magnitude impact. So street intersection at the municipality level doesn't have a great impact, although you see one risk association and a general association of reasons for street intersection. Landscape fragmentation follows the same path as the previous breeding environment feature. Higher landscape fragmentation is associated with a protective association in Costa Rica and a risk association in Chile, but it's also a very, very low magnitude impact. And it's interesting to say that although we did not find a great impact for built environment on the municipal level, there are students at Salón at the city level that found major impact for those features. So highlights and conclusions, we do found a heterogeneous association of social and built environment and cardiovascular disease mortality across all Latin American municipalities. We have the higher education attainment are related to protective associations in Latin American countries in the advanced stages of the epidemiological transition, and risk association on Latin America with countries with earlier stages of epidemiological transition. And we believe that characterizing this heterogeneity in Latin America and its associated factors is very important for local urban health policies aimed at improving health and reducing health inequalities in Latin America, especially at the local level. Thank you. Obrigado, gracias a todos. This is my personal email if you got interested in this work. You may also want to connect with us on this is my working group on social media. Please take a look at us. We are all posting new results, interesting research we are developing, and also you can find more information on our website. Thank you very much.
So we have time for a couple of questions yes. Please introduce yourself. I ask you to introduce yourself because I think it's really good to know who's doing work in the same area that you might want to connect with.
Hi, so I'm Ricky Nafani. I'm at Imperial College London on the Pathways project, so also part of the kind of Our Planet, Our Health sector at Wellcome. Fairly straightforward question, which is, could you describe a bit more what landscape fragmentation is? I appreciate you had a lot of technical detail to cover in a short amount of time. I'm just not familiar with that as a variable that describes urban form.
Mm-hmm. Well, landscape fragmentation is how urban expansion is moving forward. So you urbanize area and you reduce green area. So it's kind of this way. It's the advance of the urbanization and cities. So at the municipal level, it's harder to see an impact. But as I said in other Salivary studies, when you look at the city level and you see how bigger and greater cities are becoming, this impact get higher.
I'm going to ask you another question. I'm glad you asked that question. What about street intersection? What does that mean? If you
Okay, street intersection. Great. Street intersections are how connected cities are. It's kind of the number of streets per kilometer square. So the more connected those cities are in the municipal level may help us to understand risk or protected association in cardiovascular disease. And again, this doesn't have a great impact on municipal level, maybe because it's kind of a more similarity between and within the city. But when you look in the bigger scale, it has a greater impact.
Thank you. Any other questions from the audience? Okay, let me ask you we have a few minutes for some general questions. I'll give you the mic and pass it over to colleagues. We've obviously heard some universals here, I think, especially with how important environment is to cardiovascular disease, exposure to risk factors, et cetera. Very impressive presentations as well. I wanted to talk a little bit about, in some ways, I think your project, Luis, is a little bit connected to Deepak's in the sense of you're looking for touch points to improve the health of population in the service sector. So I wondered if you could talk, maybe ask Dr. Elsie to talk a little bit about the pharmacy issue, which is a big issue. It's much more, as you pointed out in his presentation, more trusted in some ways or more accessible than healthcare. And then this question, I think you were asked as well about how do we get the public aware of and have access to services like gyms, like exercise, et cetera, to expand the footprint of touch points with communities. Yeah.
Yeah, thank you. And I think that's it. It's a really key point, the role of the private sector around non-communicable diseases and their accessibility. And Deepak was highlighting the thing about the timings of when public facilities are open and how challenging those timings are for people living in the city, working really, really long hours. So obviously the lower socioeconomic groups are turning to what's available, what's close, what they can do within really kind of long working days and real challenging environments. So it's pharmacies, and that covers a whole spectrum of kind of really informal medicine providers right through to more kind of formal pharmacies. So those challenges around access around non-communicable diseases is just such a major issue in the context of Nepal, but I'm sure in Sri Lanka as well would be good to hear.
Okay. You want to just pass because
Yes, I think Sri Lankan data also resonates with what Deepak presented, where there are so many challenges of the poor accessing these facilities. For example, just to take from your question, so many physical built environment changes have happened in terms of walking tracks and green spaces. But once again, what you see are like really affluent people coming from in their Prados and BMWs and parking in these areas and walking in these tracks. I mean, it is a question whether the underserved populations of the Colombo Municipal Council area or the Colombo district itself actually have the time and the resources and the respite to take advantage of these facilities is a big question in Sri Lanka as well. Yeah.
Luis?
Yeah, the problem with physical activity is, from a point of view, is that for public administration, physical activity is not a responsibility for them. The offer of public administration made on physical activity is something like an offer of leisure time. Like we have to offer some little opportunities in terms of facilities and whatever, with a higher price generally, inclusive when we talk about public administrations, and they don't assume the responsibility on physical activity as a protective of the health of the people. So it's more about how the administration look physical activity as a public service or not, and we need a change to from leisure time to a public service on physical activity system.
Sounds like a good advocacy line with your information. Diane, you want to comment on this one?
Yep. Oh, I have a question for you all, actually, but I'm going to comment real quickly about something. Studying what we study, more and more, I understand that cities mold the habits, and habits are created when you interact with the city. And higher those inequalities target local policies, which are very important. And also, it's difficult for them to understand that some features may be just positive or negative, but it highly depends on how many features interact between them. So maybe one nice step that may be done is how all those features we are evaluating interact between. And then I will get into you, because I got a doubt, and maybe I understand it wrong, but those facilities you said that have major impact on the neighborhood level, right? Yeah. And lower on the city level. And
lower
in the city level?
No. Have a very great impact. If the facilities have a greater impact in the neighborhood level than the city level? No, the issue is that there are some people with worse start point on health issues that we are talking about exercise facilities, but any futures, help, whatever, to improve health are more important than other people. For example, if we are talking about two neighborhoods, one with a higher level of SES and another with a low, the city should improve the investment on low levels than higher levels, first, because the start points are different, and secondly, because the people from the high level have opportunities and chance to look for other issues to improve their health. But low SES people have no any type of chance in terms of time, cost, money, health service, etc. I answered? Yeah.
Let me just, we were out of time, but since we started late, let me ask one last question for each of you. Each of your presentations was very impressive because you seem to have been able to either tap into existing databases or access data. And one of the real issues in cities is the availability of data. Excuse me, to do this kind of work. So let me just ask you about that issue. How hard, how easy, how did you overcome it?
If I can go first, and just speaking from working with the team in Nepal, what's been really interesting is the part of the study that they didn't present was they did a large health facility assessment of all public and private facilities in Pokhara. And when we started designing it, we were like, well, within the budget, we can do a sample. So we were working out our sample. And basically, they're very engaged with the local municipality. And the municipality said, if you're going to do this, can you please do a census of every single facility? Because we don't know who's out there. We don't know who's operating. We're supposed to be responsible for regulating them, checking what they're doing, and we have no idea. So that's what the team were able to do. And that's sort of the brilliant thing about being really doing research in that kind of really embedded way within local government. So now they have a data set of all the health facilities and their preparedness for non-communicable diseases in particular. So yeah, the data is a massive challenge for local governments as well as researchers.
I will say 2 points about data collection and availability from my research. As I mentioned in my presentation as well, there was a real restriction of people of higher levels of socioeconomic status being willing to take part in these studies. So it was actually a limitation of my study, because overwhelmingly it was the very poor or the relatively poor who took part. Others would not really open their doors for us to do this door-to-door data collection. So that is one thing we experience in Sri Lanka. The other thing I want to say about the GIS mapping. Now, we took the coordinates of the household when we visited the selected household, and out of the 1,270 who consented to giving data for the first part of the study did not consent to their data coordinates to be taken into the GIS because, due to the certain situations in Sri Lanka, people think that this is some kind of a surveillance system. They have, they have very little knowledge about technology, and they are often skeptical or suspicious. So it was a subsample of data that could be taken for GIS. So that is something we experienced.
Data, the issue, any particular challenges about getting data? Just it's an issue in cities when people are trying to do this kind of work.
From our experience, a very great opportunity that we have is to count on health electronic records of the entire population. That if we wouldn't have this data, we cannot make this type of analysis stratifying by SES levels, sex, whatever. So for us, for our experience, it's very, very important to count on the support of the public health services to count on this data to could improve the knowledge to make better policies for improved health.
And I'm sure somebody in the audience is wondering about the privacy question. In terms of your agreement with presumably the providers of the electronic health record care, just quickly. You said that we're working with the public sector to get EMR data, and I'm just wanting you to comment on the agreement you had around the confidentiality issue.
This man is my boss. This man is the IP of the project.
Okay.
He achieves the data, but it's part of a great project, the Heart Healthy Hoods project with a European funding, who entitle a lot of people, a lot of data sources, and in the framework of this European project, we achieved this data with the agreement of the Madrid Public Service on Health. And maybe actually, if we don't have this project, maybe we can't achieve this data. And it's very important because our project is the only one project on this field in Madrid. Yeah. So if we didn't achieve this project, we never have this data. Okay. So it's very hard.
So those of you who want to know about this call, but see the boss during the coffee break. All right. And Diane, you want to last comment on the data issue?
Yeah. Well, combining those data was very difficult. Well, we are comparing many different countries with many different definitions of what is an administrative unit, what is a city. So Sarabao has a major work trying to create standard definitions of what is each city level of each of administrative unit and regions to make all Latin America comparable. Another great issue is that, as you saw in my slide, we don't have updated information for census data on all countries, but there's a great correlation of the social environment within time. So we don't have the most updated information, but we do have a great correlation this within time. So it's kind of accurate. So yeah, the major issues we faced was to combine those data, which is from different surveys from different countries. Is not anything is standardized in all Latin America. So this was the major one we found in our analysis.
That's great. Thank you. Yeah, I think this work on urban health is not for the faint of heart. If you're a researcher, and you must be out involved in networks, in partnerships, in the community. So well, anyway, great presentations. Thank you all. May I ask the audience to join in thanking them for their presentation.